Hello and a warm welcome to this mini webinar series. This time, basic terms to understand pandemic reporting. This webinar is presented to you by EPOS Health Management. In this presentation, we will discuss and review the epidemic curve, look into basic terminology of epidemic reporting. This presentation was made to give an overview for the non-health experts that are called to look at epidemiological information and base decisions on that for the relevant field of responsibility. A few words on EPOS. EPOS is a public health consultancy born in 1985. It provides technical assistance to governments and institutions around the world with financing from donor organizations. We are based in Bad Homburg, near Frankfurt am Main in Germany. Our services are organized in three competence areas: health policy and financing, health infrastructure and services, health service delivery. EPOS is a sister company of the GOPA Consulting Group, a leader in Germany, covering all fields of development. Myself, I am Raphaël Broniatowski, a consultant and project manager in public health. I mostly intervene in health emergencies or when health systems undergo a transition phase. I work in Francophone and Anglophone countries. Now, let's look at the epidemic curve. The classic epidemic curve that is not represented here has a bell shape. In general, we report observed cases as time passes. Cases build up as fast as transmission goes somehow. It depends on the ability to detect cases, of course, the characteristics of the transmission, and we can even have a certain parallelism with how the disease develops in the body, with a kind of incubation phase, then symptoms show up, severe cases become clinical, and it's followed by the recovery period. There are two curves to look at. The blue one that we just showed is the probable one, the one we don't know, but we imagine. It's what is really happening within the community. But the one we use to base our definitions and our actions is the observed one, the black one here. It is, as said, based on the testing quality and availability, and on the definition of what is a case. How do we do diagnostics? Now, let's look at the moments of this curve. Let's follow the black one if you wish. First, cases are coming slowly. We don't really see them until we detect the outbreak of the epidemic. The outbreak is reported the moment we reach a certain threshold. Then, cases raise. Patients seek healthcare. The system is absorbing and in fact is limited by this absorption capacity. Measures are put in place to contain the outbreak and flatten the shape of the curve. The epidemic can evolve and continue to spread, leaving its initial territory to reach new regions, even a continent, and more. When other sources of epidemic appear around the world, we call that a pandemic. Pandemics are relatively rare. But in any case, the epidemic curve is similar. We continue to raise to a certain plateau or peak that is an equilibrium where the transmissibility for that precise time and environment has reached its maximum. But factors can influence that equilibrium, and you can have another peak, higher or lower. Those are called waves. Transmissibility in the end reduces as the disease agent loses its capacity to spread for different reasons. Then it normally goes back to the pre-outbreak level or to a new set level. If the disease agent is still present at certain times or in certain areas or certain niches, we usually call that an endemic period. To facilitate outbreak management, we usually divide the epidemic curve into 4 phases. The first one, preparation and detection. The second, readiness. Then the longest one, response. And it's followed by a recovery period. We are going to look at these 4 moments, highlighting key considerations and actions. But first, a bit of terminology. The first indicator that people refer to is mortality. This is a demographic indicator, a general one. It is not disease specific. It is the number of deaths in the total population within a period. It is interesting to compare the mortality during a certain month of the epidemic with the mortality in years where the epidemic was not present, for example. Specific to the disease is morbidity, the number of cases in the total population within a period. It depends on what we call a case, how we count our population. The fatality is also an important indicator, disease specific, the proportion of deaths from the disease in the number of cases within a period. It depends also on the way we report deaths. And then incidence. This is the measure of speed. We want to know how fast it is spreading, so the number of cases within a period. Another thing we are very interested in is the prevalence, the picture. Today, what are the number of all cases in the total population? We introduced that notion before, the transmissibility. It is difficult to define this in a moving environment. We use a factor called R0, the reproduction number, or the number of cases an infected person will cause. This number is an average. It's relatively complex to build because it depends on the model you use to represent the epidemic. In the case of the COVID-19 today, as I speak, it varies from 2.5 to 5 or more, depending on the country and the moment of the epidemic. But we are interested to see the progression of this number on a specific curve. This helps us to see if we are effective in the measures we do or not. Let's look now at the phases. The first phase, preparation detection. We said it is the moment where you reach the outbreak limit. It is then that you call the outbreak. So it is dependent on your capacity to detect something out of the average within your population. It relies on your surveillance system and on some information you have about the disease agent. So of course it's easier if it's a disease that comes back and that you know already and if you've already set a threshold. If not, like in the case of COVID, it is a bit more complicated and the threshold has to be set ad posteriori. What is very important is that, especially for a new disease, this is where you have qualitative information on the disease agent, its pattern, its biology, and its spread within the population. It's where you start to get the definitions we discussed before. Most countries have established plans to respond to epidemics of different kinds. This is the time to look at these plans and coordinate the response. An example, EPOS is working in Eastern Africa with support from GIZ to support pandemic preparedness. We did so by revision of the pandemic preparedness plan, then training of responders, operationalization of the plan through standard operational procedures, field simulation, tabletop field simulation for people to own their process, and then a course curriculum and a response database for future interventions. Next phase, readiness phase. This is an action phase where you activate the response with the system you have, with the resources you have. It is very important to send investigations investigation teams to the targeted clusters, the areas where niches of population are developing the disease. You look for the presence or absence of the disease agent, and you learn about the agent. While doing so, you understand who is your at-risk population and how to defend it, and you intervene to reduce the source, to act at the disease agent directly. You communicate this information. An example of this, in Tunisia, we were acting for a general health support program called Essa Aziza, Precious Health, with EU fundings. And together with our partners, we had to adapt to the COVID pandemic and look at the first line of defense, the nurses, doctors, and practitioners of the first line, train them, support them, equip them to address at community level the progression of the epidemic at the start. The third phase is the response phase. Again, an action phase where you scale up your response, you adapt. This is the moment where hospitals are flooded with patients, like now, for example. So you change your entire strategy. You arrange workflows, you use different professionals, reorganize your service, but you continue to investigate and test, but this time also looking at the general population. And maybe you cannot test the same thing. You are not going to test the agent, but you are going to test the response to the disease agent from the bodies. You need to put in place measures, some very popular, like confinement and physical distancing, to protect the wider population. And you need to continue to communicate and educate the population. And you have communications in any direction to different targets. An important component is to correct misinformation, including competitive information from other technical agencies, global or nationals, that might undermine your credibility on the long run. So this is a very crucial part. Then with also scientific developments, you could adapt testing, treatments, and maybe start clinical trials. And all this information that will be generated, you need to capitalize and disseminate through the normal channels of research. An example of it, during the epidemic in Western Africa, the Ebola epidemic of 2014, EPOS intervened through the EU for a technical assistance project to reduce maternal and newborn mortality. It was after the peak of the epidemic, but people stopped seeking healthcare because they were afraid to get infected in the facilities. And we had a rise in maternal and newborn mortality. So while the epidemic was going down, we were trying to help strengthen the system to compensate for the deficiencies of the system for the normal pathologies. The last part, the recovery phase, is a difficult one where you have adapted your surveillance system. You know now what to look for. In theory, what you observe is closer to what is probable. Sometimes you can count on a certain level of immunity of the population. Enough people have encountered the disease agent and have a protection against it, or simply the disease agent is not transmissible enough to start a new epidemic. You might have treatment strategies and a vaccine, and a lot depends on the behavior change that you have induced before during the response phase. So how to call off the epidemic, how to say that it is over? Well, in Western Africa, during the Ebola epidemic that we discussed, it was assumed that 2 times the incubation time, so 2 times 21 days in that case, was a safe time, and that multiplying this per 2 without new cases, countries could claim that they were free from Ebola. An example of maintaining the recovery conditions in Sierra Leone, EPOS intervening through GIZ fundings to strengthen the health system, to be more resilient, have more resources, better organized, a better surveillance system and management of human resources to cope with a new epidemic. Well, I hope this short webinar was interesting for you and that you learned some notions that are useful for your daily work. If you have any question, feel free to contact us at eposhq@epos.da. Thank you very much for attending. I hope there will be another opportunity of webinar together. Goodbye.